Good evening, everyone. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 21st episode of Optometry series. The topic for today is Retinopathy of Prematurity. I'm very happy to welcome Mr. John as the moderator today. Hi, sir. Thank you so much for joining.
Hi, thank you so much.
Thank you so much for accepting our invite, sir. Thank you.
The pleasure is mine.
Thank you so much, sir.
Yeah.
Yes. So I'm very happy to introduce today's MC, Ms. Shweta, and today's presenter, Ms. Vaishnavi. Hi, Vaishnavi. Shweta, you can start to introduce about our moderator today, Kana.
Good evening to one and all present here. I'm Shweta, doing second year BSc Optometry at Dr. Agarwal Institute of Optometry. It's my pleasure to welcome you all for the 21st episode of Optom series. The topic of today's episode is optometry and did an extensive clinical practice related to retinopathy of prematurity. Sir Dunn has clinical practice both in government and private hospitals. Sir has also traveled to many districts of Tamil Nadu for ROP screening and consultation. Even after working as a corporate optometrist, he continues to practice ROP screening. He has cleared and has medical licenses of Dubai Health Authority of Abu Dhabi, Ministry of Health exam. We are very proud and happy to have you here with us, sir. The presenter for today's Ms. Vaishnavi, studying third year at the Dr. Agarwal Institute of Optometry. Ms. Vaishnavi, please start your presentation.
Thank you, Ms. Nivetha. Today's topic is Retinopathy of Prematurity. Introduction. Retinopathy of prematurity is a bilateral proliferative retinopathy occurring premature infants with a low birth weight who often have been exposed to concentration of the oxygen. Earlier, this disease was known as retrolentar fibroplasia. Over one-fourth of the world's blind children live in India. Over 22% of children's blindness in India is attributable to retinal etiologies. Retinopathy of prematurity, ROP, is the commonest and more preventable causes. Incidence of ROP varies in different neonatal units. Studies from India have ROP in 20% to 52% of retinal vascularization. Retinal vascularization gets completed at observation just before birth. The most superficial retinal vascular layer forms first, starting from the optic nerve head, peripheral edge of the retina, reaching the nasal side of the ora serrata, 36 weeks of gestation. Then, retinal vessels dive into retina, deep retinal vascular layer, outer plexiform layer. The intermediate layer then forms between the superficial and deep layers. The superficial to the inner plexiform layer, forming a well-organized network to complete the three vascular layers. Next slide. Next slide, ma'am. Etiopathogenesis. Low birth weight and decreased gestational age are the primary causative factors. Supplemental oxygen administration also forms one of the risk factors in ROP. The hallmark of the ROP pathogenesis is a biphasic pattern of initially reduced retinal vascular development and then later exuberant vascular growth of the retina into the vitreous. Hypothesis. Classical theory postulates that owing to the exposure to high concentration of oxygen, then occurs obliteration of premature retinal vessels. This is followed by neovascularization and fibrous tissue proliferation, which ultimately forms a retrolental mass. Spindle cell theory postulates the induction of retinal and vitreal neovascularization by spindle cell insulting premature retina. Premature delivery, retinal vascularization, birth of 31 and 32 weeks. Developing retina exposed to hypoxic environment, ambient and supplement, reduces angiogenic factors delaying retinal vascularization. Phase 2, neovascularization, neuroretina continues to develop angiogenic factors, especially VEGF, causes uncontrolled retinal blood vessels growth. Next slide. Risk factors. Major risk. Prematurity, low birth weight, excessive retinal oxygenation. Associated risk factors. Acidosis, anemia, hyperglycemia, blood transfusion, intraventricular hemorrhages.
For the all funders examination and for documentation purposes. By default, we are divided the retina into three different circles, basically three different zones. So as the picture depicts, it's zone 1, zone 2, and zone 3. So that is one thing which we have to know to classify the ROP. The second thing, severity of stages, which I will be explaining later. Just 5 stages. There are 5 stages where from starting to end the ROP progresses. So we are classifying the stages by 5 stages. So and the third thing is that how the blood vessels are. Vascular changes is nothing but how the vessels are, how we perceive the vessels or how we see the vessels in the retina. By that there is something called plus disease. So these are the main three categories which under which we will be classifying the ROP. So as you can see, these are those. So just to have a look, I'll just have a, we'll have a better understanding of the picture. And so I will just like to show you a quick video of an animated video through which you can understand how the disease develops basically from stage 1 to stage 5. Please tell me whether the video is playing or not.
Yes, sir. It has started, yes.
That's perfect. So as you can see here, so the zone 1 and zone 2, as you can see, so the zone 1, the first circle is vasculature, basically blood vessels are there. So on the outer one, the which is the pale colored circle, the second half circle, it is basically zone 2 and zone 3, through which there is no blood vessel. So this is our stage 1 basically. So there is a color difference between vascular, meaning blood vessels and blood vessels in the retina, and with there is a zone 2 and zone 3 where there is no blood vessels. So this difference is called zone 1 basically. And if you go to the second stage, basically second stage will develop the demarcation line. The stage 1 is just the line, just the difference between vascular and avascular retina, the area with blood vessels, the area without blood vessels. The second stage is nothing but the line will just develop and it will just grow more. Basically you will have a definitive difference between vascular and avascular area, which is not a line anymore, it is a ridge now. Basically it will have a height, it will have a width also, it is not a single line anymore. So that is the second stage. And the third stage is fibrovascular tissue formation. Basically whatever happening in the blood vessels, so what happens, the blood vessels will rupture and the blood vessels, all the contents of the blood vessels, including blood, plasma, everything will spilled into the retina. So with that note, it will be spilled on the ridges, basically the stage 2. So when it occurs, the blood vessel, the ridge will develop more, and basically it will get more thicker, to simply put it. That is our stage 3. So as you can see in the video, the blood vessel will grow on these are very fragile blood vessels. So the fragile blood vessels will break and it will release all the contents of the blood vessel into the retina. So as it does that, the stage 4 is our partial retinal detachment, in which case what happens, as you can see, so the tractions basically, so the type of retinal detachment that we are having in ROP is a tractional ROP, basically by pulling. Retinal detachment is happening because of pulling. So there is a difference between, as you can see clearly in the video, in the picture. So the blood vessels ruptured and the fibrovascular tissue is getting hardened, and it is pulling the vascular retina from the avascular retina outwards. That is our stage 4. And there is again two types, 4A and 4B, partial detachment, where the 4A includes macula. If in the retinal detachment, if retinal detachment attaches without macula, it's called 4A, and if it is with macula, it will be 4B. And our stage 5 is the total retinal detachment, basically. That is how ROP develops. Now, for more better understanding, you will just have a intersectional video which explains the same. So zone 1 vascular and zone 2 avascular retina. So the just a thin line between, just to show the difference between these two. And now the ridge that develops, it is getting a height, it's getting a width now. So stage 3, basically the blood vessels going onto the ridge and pulling the ridge, rupturing and getting hardened over the ridge, and it is pulling the retina outwards. And stage 5 is total retinal detachment. The extreme stage, the last stage is stage 5. So this is how the disease is. These are how the 5 stages are basically. So just to give you an idea, so apart from stage 5, the total retinal detachment, there are new classification that is added. This is for the therapeutic purposes and for the ophthalms to do a better understanding and plan the treatment. These are added recently. I just want to give you an idea about this one as well. So as you can see, it's 5A, 5B and 5C basically. So open funnel, closed funnel and closed funnel with anterior coupling. It's nothing but when you are doing the screening and there is a total retinal detachment happened, and if you see an optic disc when you are doing the screening, it's called open funnel. And when you don't see an optical disc when you're doing the screening, you know it is a stage 5 and you cannot see the optic disc, then it's named 5B. So and 5C is a closed funnel where you will have anterior complications. You will have anterior synechiae, the capsule, lens capsule, and the iris will be attached. All the anterior complications like anterior synechiae will be there along with the total retinal detachment where you cannot see the retina also. This is basically helps us to plan the treatment basically, because when it goes to stage 5, it is very difficult to plan the treatment basis. So nothing can be done, no laser, only vitrectomy is the only solution. And to plan the vitrectomy and how to do the surgery, so this classification will be very helpful for us. So this is about the stages now. So and the plus this is nothing but the blood vessels will be very spiral. So blood vessels will be very thicker, as you can see in the picture, and in the below part, as you can see, it will be very thicker and it will be very spiraled also, as you can see here. Hope you can see the pictures clearly. So as you can see, it's very spirally in nature. Basically, that means tortuosity. We call it technically. To simply put it, basically the blood vessels will be spiral and it will be abnormally thicker, as you can see here. Usually, when you see a normal retina, you don't see such blood vessels, thicker blood vessels. It will be thinner like this. So when you see thicker one like this, it means the presence of or plus disease basically. So there is treatment plan. So how we treat? We don't treat all the ROPs basically. So we are divided into two types: type 1 and type 2. Type 1 we will do treatment. Type 2 we will observe. That's it. So basically, if there is a zone 1 vascularization and is there any ROP plus, if there is any tortuosity of blood vessel, then we do the surgery. And zone 1 with stage 3 basically, so without plus disease. So stage 3 is nothing but the extra fibrovascular proliferation basically. When that happens, then we will know, we will do the surgery. Then zone 2 vascularization along with stage 2, either ridge formation or the extra fibrovascular tissue formation or the plus disease is there, then we will do the surgery. Everything else we will just review basically. Every 2 weeks once we will just do the review till full normal retinal vasculature is completed. That is how we do the treatment plan. So treatment plan, as you can see, these pictures depicts post surgery. So this particular baby had a ROP, zone 2 stage 2, and this is after the laser surgery is being done. This is how the retina will look like. So we'll get complication to the later part. So this is how the retina will look like, just to give you an idea. So ablation therapy is like by Ms. Vaishnavi said, it's a cryotherapy. Cryotherapy is nothing but stopping the blood vessels by ice basically. So simply put it, cryotherapy is nothing but just stop. The laser is by ice, so by cold we are stopping the blood vessels. PRP is our pan-retinal photocoagulation, it is called, and IV injection, the anti-VEGF factors, which stops the factors responsible for abnormal blood vessel growth. So VEGF nothing but vascular endothelial growth factors, which is responsible for the blood vessel growth. So this anti-VEGF will stop the blood vessel growth, which stops the ROP in turn. So it's called Bevanzumab, so which is very difficult for me to pronounce always. So they came up with a more practical name, which is Avastin. So I will use Avastin. So the anti-VEGF factors, there are some plus and minuses for both laser therapy and VEGF therapy, and I'll explain that later. And the surgery is nothing but scleral buckle we will do if there is stage 4, and if the macula is attached, then there is a point in doing a scleral buckle. So or else there is no point. Only if the macula is attached and retina is partially detached, then there is a point in doing a scleral buckle, or else there is no point in doing a scleral buckle. The ophthalms will take that out of the table, and we'll do a vitrectomy in terms of macular detachment in 4B or total retinal detachment. So the 5 classification, the 5A, 5B and 5C will give us an idea how to go about the vitrectomy surgery. So again, the main important for us is the first treatment mode, which is ablation therapy, which is cryotherapy, pan-retinal photocoagulation. I'll just again show you a quick video of how the photocoagulation is being done, so that you will have a better understanding. So this is how the photocoagulation is being done. So basically we'll do topical anesthesia to the baby's eye. Then we will have this coupling agent. We call this coupling agent to condense the light rays that we are sending into the retina. Then the ophthalms will do a freezing of the blood vessels. Basically they will freeze the blood vessels, and this is how the retina will look like after the surgery. And the complications of treatment of ROP is that, just give you the complications. So because of the laser surgery, So we are using certain lasers, so you will have cataract. So corneal laser, again, because we are putting the laser through the cornea, so of course you will have corneal laser. And because of the laser surgery which we are doing in the peripheral retina, the visual field gets restricted, and high myopia is one of the causes. And because of the scleral buckle, because we are compressing the eyeball through sclera, the band is put on the sclera, so that we are compressing the sclera in turn, which will compress the eyeball itself, the globe itself, and the rectus muscles. And because of that, we might get high myopia, strabismus, and amblyopia. So these are the complications when it comes to treatment. So when it comes to anti-VEGF, which is not we are widely using. So this is only good against, the literature says that, and the practitioners also will agree that. So the anti-VEGF factors will only effective under zone 1 ROP, whereas zone 1 ROP it is very good. But after when it reaches stage zone 2, if it reaches after stage zone 2, it is very difficult to control the ROP with anti-VEGF. And it is basically an injection which is inserted into the retina, just like how the video will show. So basically we will just put the injection onto the vitreous directly, and the injection, the IV intravitreal injection, will stops the anti-VEGF factors, basically, like I showed you. So that's how it's done. So this is basically, like I told you, most effective against only zone 1 RP, so we don't use it much. And there is side effects of using anti-VEGF factors, because the baby is already under so many complications, because it is a preterm baby, and because of that there are so many risks involved when doing anti-VEGF. So many systemic in the systemic complications are there apart from the ocular complication, so through which it is very difficult to assess it on that time of doing the surgery or the ROP. So it is very difficult to assess it at that earlier stage. That's why it's a complicated method to control the ROP. So the most commonly used during my practice also, the most commonly used is laser therapy. So now I just like to explain how an optometrist will be doing a ROP screening. So basically, so what you will be doing, an optometrist will be doing the screening and diagnosis and referral and review and follow up. So for the screening and diagnosis, basically that's why we need to focus on how to classify the zone 1, zone 2, zone 3, and the stages. Basically that's why we are emphasizing on the understanding of the stages of ROP. That's how we will diagnose this, because there is no one going to support you or anyone. You will be taking the decisions on stage. So how to do, whether do a follow-up or do a laser surgery. So that's why it's very difficult for us to understand the stages. So, and there are some prerequisites. These are the basic questions that will be asking the patient, and it is very crucial for our understanding of the particular baby, as you can see. So, whoever informing about the, because the history taking is, again, we are going to take it from the father or the mother or the staff nurse who is going to be there on the time of ROP screening. So we have to mention who's the informer, and all the other days, as you can see. So mother's age, DOD is nothing but date of delivery. These are terminologies which you have to know when you go to ROP screening. So these are common terminologies which we will be using. So date of delivery, time of delivery, and expected date of delivery. So these are something. And GA is nothing but your gestational age, and PMA is nothing but your post menstrual age, and PCA is post conceptual age. So there are some methods to calculate it. So how to calculate it, when to calculate it, you will be knowing when you go to the on tables. So I don't want to take more time on that one. And birth weight is one of the very key factor on which basis we will be doing the ROP surgery, whether to do the ROP surgery for the baby or not. And the current weight, how much weight has been gained by the baby, just to understand that. And history of phototherapy, again, and history of phototherapy, again, one of the very main factor on which basis we'll be doing the ROP. So O2 therapy and birth weight, all main two factors on which we'll be doing the ROP screening, whether to do the ROP screening for the baby or not. So depending upon these two factors, birth weight and O2 therapy, that's how we decide. And history of consanguinity marriage, basically consanguinity nesting with on the same family, basically. So on the same family tree marriage they do. So why all these are? Because these are factors of, again, um, there is no particular reason how the ROP is developing. It is an idiopathic again. So to understand, at least these are the literature says that at least these are the reasons why ROP is happening to a certain baby. And history of diabetes mellitus and hypertension for the mother, and any family history of myopia, squint, any ocular abnormalities, and history of milestones. Milestones nothing but, as you know, basically. So there are certain milestones for the baby to speak, to walk, to start seeing people. So all the milestones, if it is properly mentioned or not, and the vaccination status. So a history of milestones and vaccination status will not be available at the time of doing ROP, because you will be doing the ROP after 2 weeks of birth usually. So if it is there, it is well and good that you document it. Documentation is very, very important. If it is not, doing the follow-up, it is better to do it when it is available. So this documentation is very, very important for the ROP screening. And this is how we do the ROP screening. Basically, the prerequisites, as you can see, the kit will have red cam, basically retinal cam, and or indirect retinoscopy or ophthalmoscopy. Sorry, that is an indirect ophthalmoscopy. So indirect ophthalmoscopy, we are mostly handled by ophthalm. It is very, it's not a one-day process to learn. So that's why we usually deal with red cam. We call it as red cam, and you will get speculums. Speculums will help us to keep the baby's eye open, because baby is not going to, it is not like adult, it is a baby, it is not going to keep your eyes open for us to screen, basically. So this is called speculum. This speculum will help us to open the baby's eyelids and make it easy for us to do the screening, and topical anesthesia and dilating drops. So basically, so and how we filter the babies, because there will be hundreds of babies born in a day. So how we filter is basically less than 30 weeks of gestation. So in European countries the practice is 32 weeks. Here we keep it as 30 weeks just to be sure, not taking any risk. And weight will be less than 1500. Again in European countries is 1200. And review, so review will be every 2 weeks once. So how we will do, as you can see, you see the probe here. So you see the probe here, this is the probe and this is the camera, so which will go on to the baby's cornea. Basically we'll put this on the baby's cornea. Before doing that, we will be dilating the baby's eyes using topical dilating drops, basically. So with tropicamide or psychopentalate will be used depending upon the baby's condition. So it will take so much time to do the preparations, because it is not going to, usually when we do the dilation it will take at least 20 minutes to 40 minutes. For when it comes to babies, the same case, again it takes more than 40 minutes sometime. So it always better to call the hospital or the staff nurse to dilate the baby size before you visit it, which will make the make your job more easy. Basically when you go there and dilate draw drops, it will take more time, because we will be doing, when you go to out of Chennai or out of urban areas, in the rural area, there will be, you will see up to 100 babies in a day. So it is very difficult to you go there and dilate the drop. So it is better to ask the staff nurse to dilate it, and so that it will be ready for you to do the surgery when you, do the laser screening when you go there. So as you can see, these are the pedals. One is for the brightness and one is for the focus, basically, which will be handled by your foot. These are foot pedals. So, and this lab, there will be this is the red cam unit. It will be connected to a laptop. So it will be, when you do the screening lively, you will see the picture here as depicted in the picture. This is how you will see the picture as live. So it is very easy to do, and it is very, satisfying to see the baby's retina at sometimes. So this is how you do. You will do with the speculum. You will open the baby's lids. You will put the solution, and you will, when it's fully dilated, you will just keep the probe in the baby's cornea and you will check. So there are few techniques involved. When you go to specific ROP screening practitioner, you will know how to see the ora serrata, because zone 3 and ora serrata is very difficult to see till ora serrata. So the techniques you will be learning when you go as a ROP practitioner. So this is how we do the screening. Hope I covered everything. Okay, so that is how we do the screening. After doing the screening, you will just do a 2 weeks, you will decide whether to do a laser surgery or do a uh, review. So depending upon that, you will send the baby to the practitioner. So that is how it is. Then the key takeaways. So these are the 3 things we'll be doing repeatedly to ROP baby. First is screening, monitoring, and reviewing. So these 3 things you do, so you will save a baby from a ROP, getting ROP and becoming a blind baby. That is from my side. So if there are any questions, I will be opening to questions now.
Yes, sir. There are a couple of questions in YouTube.
Yeah, sure.
The first question is there ways to prevent ROP in premature babies?
In premature babies.
Yeah.
Okay.
Can we prevent ROP?
Or no, actually, there is no ways to prevent a premature, but you can take a precautionary measures as such. Where, as I told you in the birth history taking, so you can always avoid the consanguinity marriage. So it is basically when the literature says that. So the consanguinity marriage, usually the babies which comes from a consanguinity marriage is usually to be a ROP baby. And in my practice, I have seen that not in Chennai, in the outer areas of Chennai, I've observed that. So there are so many marriages which happen. There is a huge age gap between a father and mother. So usually the father being the eldest one and the mother being the youngest one. So I've seen up to 15 to 20 years also in TN, Tamil Nadu basically. So that also I in my observation, so where cities like Chennai don't have, you will get 5 to 6 babies in a day in a hospital. Whereas when you go to outer, you are getting up to, like I told you, 80 to 100 babies. Where these consanguinity marriage and the marriage between the age gap is too high. So that maybe we can do that. In which case we can avoid, I would say. So from my observation again, but there is no literature don't have any protocols for this kind of prevention as such. So it is only how we manage it and treat it. There is no preventive measures such as only precautionary measures.
Another question, sir. What is the long-term effect on vision if the baby is not treated?
If the baby is not treated, again it will be a total retinal detachment. So again, unfortunately it will be a bilateral condition. It will not be unilateral. Also, it is a bilateral condition. So it is again, even if you treat also, there are some complications. Definitely there will be complications, but when you compare, so if you don't treat it, again, blindness. ROP being one of the leading cause of childhood blindness, so that's the reason. Blindness, simply.
Okay, so one same kind of question.
Yeah.
How does the ROP impact vision as the individual grow older?
ROP impact vision. So again, we have to take it as a ROP treated baby, ROP
Not treated.
baby not treated. So basically, if you treat the ROP baby, depending upon what type of treatment that you do, like I told you, if you do a laser surgery, of course, the peripheral retina is going to be affected. In turn, where you will lose the visual field basically. So how much ever ROP is there, so that is how much complication that you are going to get. And if you are doing a laser surgery, how much ever area that you are covering with the laser, and that is how much the visual field is going to get hurt. So, and unless and until macula is not getting affected, there won't be any defects in the, or any decrease in the visual acuity as such. So, and if you do a buckle in 4A, there is a partial detachment, and the retina is and the macula is not detached, it is attached. So in 4A, if you when you do a scleral buckling, where you will put a band onto the sclera while forcefully compressing the globe to retina to get attached basically. So in that case, you will be compressing the rectus muscles, all the rectus muscles, where you might get mechanical strabismus, or in terms of scleral buckling, again you are compressing the globe, where you might get the globe to be enlarged more. In turn, you will get high myopia and amblyopia as well. So that is one. And the second, again, the fourth stage, the vitrectomy basically. When you do vitrectomy, again depending upon what type of vitrectomy that you do, so there are stages. The prognosis is it's when it comes to 4A and 5, the prognosis is very bad. There is no prognosis at all. So but whether it will be a counting fingers, whether it will be a light perception, depending upon the severity only, and we cannot say anything at the time of doing the ROP screening. We have to see the reviews, and we have to follow the baby throughout the uh, throughout the throughout the ROP. And but these are the possible outcomes of doing without the surgeries, and these are the complications.
So thank you, sir. Those are the questions from YouTube. I got
Okay.
another question.
Yeah.
Since you are involved in active screening in
Yeah.
both government and private hospitals in Tamil Nadu, what do you
Yes.
think about the awareness among the parents for
Yeah.
ROP?
Thank you for asking this question. So it is a very good question actually. So it's thank you for the question, whoever asked it. So awareness is when it comes to Chennai like areas, it is okay. So because whatever the doctor is saying, the people in Chennai are slightly aware comparing to the other outside Chennai. So people are actually aware, and they are agreeing to the treatment method and everything we say. So when it comes to out of Chennai, where you go to rural areas, so people are not that well aware. In which case, we have to be fully prepared to tell them how they will understand. So what I will always do, if you do technical things, they won't understand. You have to give them the worst case scenario always. That is how I do it, because this is for the baby's good, and I will be giving the worst case scenario always. So in which case it will be like the blindness. So even if we say that, even if you fully understand the disease, you fully give the complications, you tell them that this will happen, blindness will happen, there are still patients who don't understand the depth of the condition. I just like to share one incident which happened to me, if I'm allowed.
Yeah,
So
yeah, sure, sir, sure.
yeah, sure. So there was one ROP which I did, and ROP screening was done. There were 8 babies, so I did counseling to all the 8 babies parents basically. And after doing the screening, I just left the hospital, and when coming back, I got the call from one of the parents. The father just called, and he asked me, uh, after explaining everything, he asked me, sir, it is plus or minus? So I took some time for me to realize what he is asking. So what happened, he has a relative who works in an optical or ophthalmological background. So when he shared the same with this, because he is the person who the father trusts, so he asked that whether it is a plus or minus. So even this is how the understanding is basically. So unfortunately, he did not come for the ROP. So when we went for the surgery, when we went for the follow-up, it was a total RD. He did not come. So that also happens. Even when you take so much time, you put your so much efforts, time, money, and you're going for the uh, screening, you're doing the screening and doing the ROP. And when we are doing the practice, I was blessed with very good hospital naftals, and we are blessed with very good patrons, where all the laser surgeries were sponsored basically. It was a free laser surgery. Screening, treatment, follow-up, everything was free of cost. Only the person has to come, we'll do the laser, and we will do everything. They just have to agree to it. That's the only thing they have to do. Even we are taking care of all the expenses also, because when it comes to out of Chennai, when you come, so the NICU, where you will get special ambulances for neonates, everything was free. Even though we are doing all these things, but the parents are not aware of it. So it is very difficult to teach or educate the parents to of the importance of ROP, I would say. Yeah, hope that answers the question.
Yes, so thank you so much for sharing that experience, actually.
Yeah. Yeah.
Okay, so one last question to Mr. John. Okay, so
Yeah.
corporate optometrist and ROP screening. So how do you juggle between these? So why?
Okay, okay. So basically, can I get a clarity on that question, please?
Okay, so you work as corporate optometrist, no?
Yes, yes,
And but you were interested in ROP screening earlier. So now
yes,
also you continue to practice.
yes, 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 yes.
So why and how you managed to do both?
So basically, what you do when you do an ROP screening, so apart from the regular clinical practice, ROP screening is very close to my heart because I was doing both clinical, regular, comprehensive clinical practice for adults as well. But when you do that ROP screening, it's something, it gives you some satisfaction. So it is the babies. So it is unless and until you don't do the screening, the baby is going to be blind. That's the end basically. So you are there deciding whether the baby will get a vision or not. If this baby, when it become an adult, it is going to have a vision or no vision. It's going to see the world or going to be blind. So you are someone to decide that. So I liked it very much. And when you interact with the babies, when you go to the experience, the practice, when you get it, it is very satisfying, I would say. So that is why even when I left my clinical practice, when I came to corporate practice, I was doing an independent practice also. So where I will be called by the certain hospitals. So and I will do ROP screening and consultation on a day-to-day basis. So that's why I would say it is an experience that you have to have. You cannot explain it in words. It's an experience. Yeah.
So, thank you, John, for inspiring. Actually, thank
Yeah,
you.
yeah. Thank you so much.
Yes. So those are the questions. So thank you
Yeah.
so much, Mr. John, for joining for the session.
Yeah, thank you for having me. Thank you, Ms. Komati, for coordinating everything. And I like to thank Anshika ma'am for it as well. So being one of my inspirations when I started the optometry, because Anshika ma'am is my faculty. So it was very good, and I feel honored to be called by Anshika ma'am and other faculties as well. Thank you so much for having me, and hope to see you guys in future as well.
We would like to host you on another wonderful platform. Thank you so much.
Sure. Definitely. Thank you so much for having me.
Dear audiences, thank you so much for your continuous support towards the optometry series. If you like this video, give a thumbs up and share with your friends. The announcement for today is internship in optometry is open at Dr. Agarwal's Institute of Optometry and Dr. Agarwal's Eye Hospital. Fellowship in clinical optometry and integrated fellowship with research is also open. For knowing about more details, please call for the course coordinator. The number will be given in the description box. Meet you all in the next wonderful episode. Thank you all so much. Thank you, sir.
Thank you so much. You guys have a good day.
Thank you.